Okay, so we talked about, actually this is a slide we can move on. I'm going to talk more about the non-pharmacologic measures, and these are probably the most important aspect of the guidelines. We want to talk about the things that people can do to change their blood pressure before even approaching drugs, unless the blood pressure has been so bad for so long that you better start with drugs, as we discussed. Weight loss, sodium reduction, being physically active, not so much alcohol, never cigarettes. If we do that, we do pretty well. So what do we actually get? If you lose weight, you can get 5 to 20 millimeters of mercury off your blood pressure. The DASH eating pattern, which is a lot of fruits and vegetables and low-fat dairy was included. I know a lot of us wouldn't do that, but that's the way the study was done, and that's the randomized trial data. So that has a large impact, up to 14 millimeters. Getting the sodium down and making sure that it's as low as that you can reasonably make it has good data. Physical activity as well, at least 30 minutes per day, which is hopefully something that everyone can do, and moderating the alcohol consumption. Okay. Now, if you look at the data for that, these are so-called, and when you write guidelines, you're supposed to say what the level of evidence at LOE is and how high the recommendation ranks. And these are all 1A recommendations, meaning that there is plenty of high-quality evidence, okay, for each of these aspects. So no question about it that's what we should be doing. And they're additive. Okay, so you lose the weight, blood pressure can fall a good 4 or 5 millimeters. I would put in green, of course, the more fruits and vegetables, 11, maybe even 14 millimeters. How much sodium should be in your diet? This is argued back and forth by multiple guidelines. We're saying less than 1,500 milligrams per day. How about potassium? Adding potassium and adding it up so that you're up around 3,500 milligrams per day is really good. So, you know, people look at the DASH diet. So I threw this slide in, published by the DASH diet people. Again, randomized trial, looked at a lot of people, looked at the outcomes, and what they were able to see is that the drop in blood pressure really depends on how much of a fruit and vegetable diet you're actually doing. Is it new? No, this goes back to the Kempner rice diet back in the 1930s, okay? But the data is very clear that the more fruits and vegetables you do in the DASH diet, meaning less animal products, the lower the blood pressure gets. But focusing on them lowers the blood pressure. Now, what's the evidence outside of DASH? There's plenty. So this is actually put together by Neil Barnard's group, and there they are. And again, I know there's only 3 people over there who can see the names of the authors. You don't have to see the names, just see that the number of studies that say that if you do a vegetarian diet, and even a wide variety of kinds of vegetarian diets, you will lower your blood pressure. Okay? But the more plant-based you are, the better. Don't want to skip the physical activity part. Aerobic exercise, dynamic resistance exercise, isometric exercise. Believe it or not, they all lower the blood pressure 4 to 5 millimeters of mercury, and they are additive. So spend some time in the gym focusing on it. And moderating alcohol intake, less than 1 drink per day for women, less than 2 drinks per day for men. That can actually, if a person is drinking more than that, you can get another 4 millimeters of mercury off the blood pressure. So we really do want to do lifestyle as much as possible. And once you've maximized everything that you can do with that, then we start drugs, okay? And it's worth talking about because there are some differences between what we said about drugs, and these are things that lay people should understand, because not every doctor has actually read our guidelines, and you might want to give them a copy, okay, sometimes. But it's really important to make sure that that blood pressure is low if the person is at higher risk. That is, the more risk factors you have, the more targeted organ damage, the more you should be using drugs early. And we make sure that we're trying to prevent cardiovascular disease if a person has a 10-year risk of more than 10%. Okay? Now, what is that 10%? Has everybody heard of the American College of Cardiology, ASCVD risk calculator? Anybody? Anybody? Just one? Okay. So you can, two, great. You can actually, it's an app for your phone that you can download. That is a great party tool, okay? You pull it out and you say, what's your blood pressure? What was your last cholesterol? What's the HDL? What's the LDL? How old are you? Are you African American? It asks all the questions, diabetic, smoking, etc. And at the end, you push the button and it tells you your 10-year risk of heart attack, stroke, and death, okay? And so why would you do that at a party? Because that's the only way we're going to get a hold of this, is to let people who are at risk know. So we actually do this at Rush with a community program with the app. We did Veggie Fest a couple of times. We go into churches. We ask people to sign up. Come on, we do a blood test. Find out if your hemoglobin A1C is elevated. What's your blood pressure? Put all those things in. We call it the Helping Everyone Assess Risk Today, which of course spells heart. And that app is incredibly useful to try to tell people who ought to be going back and seeing their doctor sooner rather than later. Okay, so if you do your little app and your risk is more than 10%, you should be treated early. Okay, there's a picture of the output, because you can actually get it. It doesn't have to be the app. You can get it online as well. You can put in the data online. It's not going to store it or anything like that, and tell you exactly what your risk is. So hopefully everyone will look it up, ACCAHA risk calculator, and go ahead and do your own risk. Okay, all right. So how about, I'm sorry, go back to it? Okay. Sure, take a picture or just type it in, ACCAHA risk calculator. Okay. I see a lot of shutterbugs out there. This is good, all right? They're going to wonder when they see the spike in the activity. But yes, you should. This would be a great gift for all your friends for Groundhog Day. Okay, send them a link to measure their risk. Okay, got it? Okay, all right. All right. Let's talk about the blood pressure goal. Again, it really depends on the risk. If the person has a higher risk, more than 10% risk, those are the people where you want the blood pressure to be less than 130. Okay? If you have other markers for increased risk, particularly the cardiovascular disease, diabetes, you really do everything, and they're all shown on this slide, and nice to take a picture of it. You find yourself and your friends on this slide. Diabetes, chronic kidney disease. The only one where you give a little bit of room is actually the third line from the bottom. If you have had a stroke already, there obviously is some concern about dropping the blood pressure too soon. Okay, after a stroke, you want the blood pressure to stay a little bit higher, but not for long. But if you're doing this for stroke prevention, you use a threshold of 140. Okay, if you have no disease whatsoever, you also use 140 if your risk is low. But other than that, pretty much you're using 130 as the threshold for starting therapy. And the blood pressure goal is going to be less than 130 for everyone. Okay? Medications. Now, this one is probably something you would think, why would a doctor come and start talking to mostly lay people about drugs? Well, it's mostly because we have a problem with this. The data has changed. Dr. Shore mentioned this in the little disclaimer, that everything changes all the time. The way I tend to say it is that, medical knowledge doubles every 2 years, and in cardiology it seems to double every year. And things that we used to do 2 years ago are just not right anymore. And so it is important for everyone who is on a drug that we're no longer supposed to be using, that they go back to their doctor and say, hey, did you look at the ACCAHA guidelines? And I think this is one of the ways that we can help doctors help their patients, is by keeping them informed. Because they're dealing with a whole lot of stuff, and they may not be focusing on this one tiny little guideline, which I think is the biggest guideline. Okay, all right, so with that said, we do much more with calcium channel blockers than we did with the previous guidelines, and they are pretty prominent in most of folks' guidelines from around the world, and so there's a lot of agreement about that. But that middle column, beta blockers, no more beta blockers. Now, there are a couple of them that do pretty well, but most of them we don't do. If you haven't heard of a beta blocker, good, okay? If you have heard of it, they're all the drugs that end in LOL, but it really isn't laugh out loud, okay? But if you're on particularly metoprolol or atenolol, these are drugs that we have tried to remove from the use of for high blood pressure. There are plenty of good reasons to be on those drugs, and sometimes a person with high blood pressure is on those drugs because of something else. I could just try to list them for you, but the list is incredibly long. There are aortic aneurysms, a person who has heart failure, a person who has rhythm disturbance from the upper chamber, rhythm disturbance for the lower chamber, migraine headaches, essential tremor, stage fright. There's loads of reasons to use beta blockers, just not hypertension, okay? All right. Then the next thing that we dealt with, which is a common question that everyone who has high blood pressure has to sort of make this choice along with their doctor, is do you start with one drug and then escalate up that drug until you get to some side effect or something, or do you start with combination drugs? Well, it turns out that the best evidence is for using lower doses of combination drugs rather than trying to escalate a single drug up to some level where it gives you real problems. So if you combine drugs from different classes, it's actually 5 times more effective at lowering blood pressure than just adding a second agent. You know, even though we did that for 40 years, it turns out that that's not the best way to do it, okay? So in terms of thresholds and recommendations, I think you've got the idea that we're going to take most of our population. We start after we've done everything we can with lifestyle, unless they have target organ damage. Then we're doing it early on. That's the summary of this algorithm slide. And it's nice to take a picture of it, or you can look it up online because it really is helpful to people, their families, and their physicians. Okay? All right. So I'm going to, the last couple of lines here are about the follow-up. That is, no one has ever really talked about, you kind of learned it in medical school, you learn it as a, internal medicine training. When do you follow up a patient, who has high blood pressure? You've made an intervention. It could be cut the sodium, exercise every day, or I'm starting you on, a combination drug pill. When do you follow them up? Well, you really should be following them up fairly much sooner than we used to. I'm not going to start you on a drug and say, thanks, come back in 6 months. Okay? I need to know within several weeks that your blood pressure is under control, or I need to make the next move. Okay? So hopefully we're rolling that backwards a little bit, and we're trying to see at least on a monthly basis that the patient is controlled. And how do we determine control? Was it home blood pressure or office blood pressure? Home, absolutely. Okay, fantastic. Okay, so we have been heavily criticized for, I'm doing pretty well on this, okay. So we have been heavily criticized for changing that threshold. I want to just, and your physician, when you bring your mom to the doctor and the blood pressure is 135 and they tell you that's okay, you want to be able to fight that battle a little bit. Talk about the SPRINT trial, okay, which was published in the New England Journal of Medicine a couple years ago. And they actually did try 140, which was the standard target before, versus 120, okay, which was like almost unheard of, okay? And so the SPRINT trial actually enrolled a lot of people, had a lot of people who were older, which was the major concern. It had really the good demographics between all of the groups that were studied. Intensive therapy versus standard therapy, 120 for the target versus 140. And if you look at the primary outcome, what you see is that going for 120, they didn't make it. They made it to 121. The standard group, they undershot 140. They got to an average of 136. So, in concept, it was 120 versus 140. In reality, it was 121 versus 136. And yet you saw a dramatic reduction in heart failure, in cardiovascular death, total mortality, okay? All of them substantially reduced. Death from any cause, death of any kind of cardiovascular disease, all of them were reduced. And so people, and there are a lot of people who say that the study was flawed, that our guidelines are flawed, that blood pressure should be 150 if you're over 60. They're still saying that. It's mostly primary care, not cardiology, not kidney doctors, not neurologists, okay, who deal with the strokes. It turns out that the data is fairly strong, that this is something that if you do this for your patients, you will get better outcomes. The change in outcome is actually related to how much you change the blood pressure. And so this is a lot of statistics on this slide showing you the marked improvement in outcome. If you take the highest blood pressure, you get it down to that 120 to 124 range, you get the best outcome. Okay. Okay, so what is the pushback? It's about older people, that if you give them enough drugs, you get the blood pressure lower than 130, that they're all going to pass out, and they're going to hit their heads, and they're going to have, they're going to break their hip, and that they're going to die faster. That basically is the idea of leaving older people with higher blood pressures. Well, as you saw, the SPRINT trial had a lot of people who were over 75. And when you looked at the outcomes, what you saw is that the death rate was substantially lower if the blood pressure was lower, okay? And so then you take the data and you divide it into three groups. People who are frail, people who are not frail, and people who are in between. And guess what? The death rate was lower in all three groups. So there really is no one. I'm not, I'm saying no one in general, but in a particular office visit with a patient, the thing that I like to do if I'm concerned about the blood pressure being too low is make sure, make sure that you're measuring the blood pressure sitting and standing, because a lot of older people will get dizzy when they stand up because the blood vessels are stiff and the blood pressure drops a lot when they stand up. And so if that's the major concern, then you have to be a little bit, in an individual case, you have to be a little bit more careful with the therapy and leave the blood pressure sitting a little higher so that people are not getting dizzy and falling. But in general, you really should be going lower. And so adults over age 65, we try to, particularly if they have a lot of issues going on, we try to get the blood pressure down below 130, but you have to make those as individual decisions and assess a person's risk-benefit on an individual basis. That's really what our guidelines say. What are the things that happen? People passing out, people falling, getting really low heart rates, getting electrolyte, potassium, sodium issues, having acute kidney injury. Does it happen if you use the drugs? Yeah, but you're saving people's lives at the same time. Whenever we're using a lot of drugs in the older population, we have to bring them back and measure everything to make sure that we're not over-treating. Because we really don't want people passing out and falling. Ultimately, if you look at the intensive therapy in SPRINT for the older people versus the standard therapy, there really were not a lot of differences based on that, on the blood pressure. The fact that you're using drugs is going to cause some kidney injury in some people while you're saving their life. And the non-reversible kidney injury where somebody ends up on dialysis, extremely rare. you're going to save more people from dialysis than you're going to cause by a lot. Okay. This is actually a summary of what I just said. Acute AKI is acute kidney injury. It does happen, but permanent kidney injury, really not very common. And so the kidney function actually does improve, and changing the blood pressure threshold didn't seem to make an impact on that. Okay. So I've gone through a lot of stuff, and I recognize that some of it's foreign material, but there are sort of the four major take-home points. If there are questions about blood pressure, we've tried as much as we can to answer them in the 2017 hypertension guideline. The biggest update would be that the blood pressure level for prompting treatment, we've reduced it from 140 in the old guidelines to 130 now. For those who are less than 60, and from 150 in the people who are over 60, again, down to 130. That we're really aiming with the lifestyle therapy to get a blood pressure less than 130. If it's not working, then we do use drug therapy, again, targeting less than 130. And we remember that we have to treat the patients sooner if they have a high risk of cardiovascular disease, such as diabetes, chronic kidney disease, or if they already have target organ damage, or now that you all have your ACC risk calculator, more than a 10% 10-year risk. All right. What's going to be the impact of our guidelines? Well, they've been out about a year and a quarter now. Hopefully, we're going to see a lot more reliance on home blood pressures, not being treated just by what happens in the office, because we don't want to miss the masked hypertension or overtreat the people with office hypertension. But when you look at the implications for treatment, you will have a lot more people who will require medication, but it's a small percentage compared to the number of people who are diagnosed with hypertension, because we have a much greater emphasis on lifestyle modification. Okay, and with that, I want to say thank you and open it up for questions.